Good afternoon and welcome to everybody to the follow-up webinar for, in other words, combating stigma and transforming culture through language change. My name is Lori Blockett. I am the Drug-Free Communities Coordinator working with Wright County Public Health and the Mentorship, Education, and Drug Awareness Coalition, otherwise known as MEDA. These events, both the in-person from August 12th and today, were made possible by a 5-year Drug-Free Communities grant that MEDA was awarded earlier this year. MEDA and Wright County Health and Human Services as a whole have joined forces to promote and support these events. I'd like to thank Stacy Bezanin with Alina Health's Change to Chill program. That's a really hard one to say. I always goof up on that. For providing this professional Zoom platform and for editing and preparing the recording for both presentations. MEDA's mission is to educate youth, families, and the community on the dangers of substance use and misuse by creating awareness and fostering mentorship through sustainable efforts. If our mission is a part of your personal or your organizational mission, contact me afterwards. We can discuss ways in which we can collaborate. So all of you should have attended our original event from August 12th, where Dr. Ilona Balasanova came in person, and you might have attended either in person or online, or maybe you're one of the people that saw the playback. Over the next hour, Dr. Balasanova will give an overview of the information and then allow for your questions. So feel free to use the chat box and send questions. You can either send them directly to me, or you can have everyone see your question if you want. I'm actually going to read Dr. Balasanova's full bio this time, because every time I read it, I understand a little bit more how she's able to put this new lens on addiction and allow us all to see it in such a unique and profound way. So Dr. Ilona Balasanova is an assistant professor in the Department of Psychiatry at the University of Nebraska Medical Center. She is duly board certified in psychiatry and addiction medicine with specialized expertise in integrated treatment for substance use disorders co-occurring with other psychiatric conditions. After obtaining her undergraduate degree from the Johns Hopkins University, Dr. Balasanova went on to earn her MD at Harvard Medical School and completed residency training at Boston University Medical Center. As the Director for Addiction Psychiatry Education for the Department of Psychiatry in the College of Medicine, Dr. Balasanova has developed novel education programs for medical students, residents, fellows, and allied health professionals. She is the founder and director of the Longitudinal Integrated Mental Health Substance Use Outpatient Clinic, an internationally recognized clinical experience for Creighton University psychiatry residents. Dr. Balasanova also founded and directs the Outpatient Addiction Psychiatry Clinic and also developed and now co-directs the Inpatient Addiction Psychiatry Consultation Liaison Service, both at the Nebraska Medical Center. Dr. Balasanova's professional interests lie at the intersection of medical education and stigma reduction. She has presented and published nationally and internationally on addiction psychiatry education and destigmatizing substance use disorders. In recognition of this work, Dr. Balasanova was awarded the prestigious American Medical Association Foundation Award for Health Education in the year 2020. It is my pleasure and honor to present to you Dr. Ilona Balasanova.
Thank you so much, Lori, for that very kind introduction. I'm really excited to do this follow-up. It was a lot of fun going to Minnesota with my family in August. So I'm hoping we can continue the conversation on stigma and harm reduction. And we will largely focus on some of the issues we discussed the first time. So I don't have any disclosures. Here is our objectives for today. So it's going to be a shorter presentation with a larger component of interactive Q&A, which I'm really looking forward to. So we'll first just review some of the terminology that we introduced back in August. We'll review addiction and substance use disorder and related terminology. We'll also review some of the interventions that we discussed about reducing addiction stigma and providing evidence-based care. And then we'll end with some questions from Wright County and updates, what has changed, what is on the horizon, and all of the things going on in Wright County on this subject today. So addiction. It's a word that we hear very often. Actually, just recently, the numbers came out over, I think, 93,000 opioid overdoses estimated in the year 2020, which is a sharp increase from the previous year, which we do think COVID had much to do with that. But the numbers are rising, and the prescriptions of opioids are decreasing. They've gone down by like 44%, and yet our overdoses have gone up. So it is still a very pertinent issue. And it's important that we define it accurately, what addiction is and what it's not. So it's a chronic brain disease. It has the potential for recurrence and recovery. It's something somebody can live with their entire life and yet be in remission from it their entire life and not display any symptoms. The major part about it is that it's associated with uncontrolled or compulsive use of a substance. So that lack of control piece is really what defines addiction, where you have no control over your use and you're using despite negative consequences because your brain's just been hijacked. So again, just the chronic brain disease model of addiction really speaks to these two components, the relapse and the recovery. And they're part and parcel of this disease, much like if somebody has diabetes, they're going to have periods of time where their blood sugar goes up and it goes higher because their disease has progressed. And there's other times that it's in check and they're doing really well. And that is very much similar to how the chronic disease of addiction plays out. And again, this idea of uncontrolled use despite negative consequences is often what you hear from folks that have transitioned to now having a substance use disorder from simply misusing the medications or whatever substances. You'll often hear them say things like, well, I was just using it socially with friends, and now I'm using it just to feel normal. Like I don't even get pleasure out of it anymore, but I have to use it every morning just so I can get through my day. And that really just speaks to the powerful hold that addiction has over the brain. So a severe substance use disorder is what we call an addiction. Colloquially, we sometimes use the term addiction to imply substance use disorder. And that is also a medical illness caused by repeated misuse of a substance. Now, these definitions come from the US Surgeon General from the Facing Addiction in America report on alcohol, drugs, and health, which was a sentinel report that came out in 2016 and was really heralded as the first major report of its kind since the tobacco report of the 60s, which was, of course, transformational in telling us that cigarettes were not good for us. So again, in this report, they talk about substance use disorder and how it develops gradually over time, leading to brain changes. It's not the sort of thing where you use a substance one time. Sometimes you'll hear people say like, oh, use it one time and you're hooked. That's just not how it works. You may have a predisposition to maybe liking the feeling that you get from using a particular substance, but that is not enough time for your brain to change. That it requires repeated use, repeated exposure, and that is exactly what happens with a substance use disorder. Now, substance misuse, again, repeated misuse leads to a substance use disorder. What is misuse? So misuse is defined as the use of any substance in a way that can cause harm to the individual or those around them. So for example, I like to use the alcohol example. If somebody is having a drink out with friends and they're over 21, that is regular substance use. It's legal, it's socially appropriate, there's nothing wrong with it. But then if they had a few too many drinks and then got behind the wheel of a car, well, that's substance misuse, because now you're misusing alcohol, you're putting yourself at risk, you're putting others at risk. Likewise, with prescription medications, it's when you're taking those medications not as prescribed. Maybe you're taking a little bit more because you notice you feel a little buzzed, when you take your pain medicine or something like that. And so that too would constitute misuse. This is a great graphic that shows the parts of the brain that really are impacted with addiction. So you have your prefrontal cortex, which is that really front executive decision-making center of the brain, which separates us from the chimpanzees and our next mammalian counterparts closest to us. It allows us to plan actions, to execute actions, and to inhibit actions. So again, when we talk about uncontrolled use, that really does hit that part of the brain where that inhibitory mechanism is not functioning appropriately. So the brain changes result primarily in impaired executive function, right? Although all three areas here are impacted, the prefrontal cortex, basal ganglia, and extended amygdala, really it's that executive decision-making center that is impacted. And if you think about it, when you know somebody with a substance use disorder, it sometimes gets to a point where they're just not making great decisions anymore. And you kind of wonder, like, why are they not making these great decisions? They know these are not great decisions. And that's why, because it's that part of the brain that is responsible for making great decisions that simply isn't working properly. The problems this causes then is the problems with self-control. So that inhibitory mechanism is not functioning appropriately. So you have problems with self-control and decision-making. So you're not making great decisions and you're not able to stop using or prevent yourself from using because of that lack of self-control. So the continuum then is from substance use, which is okay, and there's nothing wrong with it if it's legal and you're of age, which can lead to substance misuse, which again is using in a way that causes harm to yourself or others. And that can cause a substance use disorder if you do it over time repeatedly, and ultimately culminates with an addiction, which is the most severe type of substance use disorder. And so that's really the progression of how this develops. And for some, it can happen very quickly. And for others, it takes longer, right? For some, it can happen in a span of months. For others, years, decades even. It just depends on your natural physiology and how you are wired to respond to the substance in question. So more importantly, even than understanding what addiction is, I really like talking about what addiction isn't. And it's not a moral failing. It's not a character deficit. It's not bad behavior, although sometimes bad behaviors are a symptom of what an addiction might do to somebody, but that is not what an addiction is. Poor decision making, which again can be a symptom of an addiction, but it doesn't define the disease. And ultimately, it is not a voluntary choice, right? Nobody ever wants to develop an addiction. You know, I think about in kindergarten, they ask you to raise your hand if you want to be a firefighter when you grow up, or if you want to be a police officer. You know, if they're to ask who wants to have an addiction, I don't think anybody's hands would be raised because nobody wants that, right? Nobody looks forward to that. Nobody anticipates that for themselves. So it certainly is not a voluntary choice, and we shouldn't treat it as such. Now, the language of addiction truly matters. The social fabric, of our society is communicated through language. The way that we are all tied together, the way that we understand one another, appreciate each other is all through how we talk to each other, how we talk about each other, and listening as well. And all of that requires language. So language plays a very key role in addiction and destigmatizing addiction, and simply by talking about addiction. So the words that we choose truly matter. We should be saying things that the Surgeon General outlines for us, like substance use disorder, substance misuse, substance use, addiction, a person with a substance use disorder. We certainly should not be saying things like addict or drug abuser or alcoholic, because all of those are labeling somebody for their disease and taking away the humanity of that person, right? Where that is all they are as an addict. They're not seen as, Joe Smith with an addiction, which is very different than just saying, oh, it's just an addict. It's so dismissive. And it, again, just takes away the humanity of that individual and the shared humanity that we have with each other. Terms like replacement therapy when talking about medications for opioid use disorder or alcohol use disorder. Again, very erroneous thought that perhaps replacing one addiction for another happens when you use a medication to treat addiction, which is not true at all. And yet that is what replacement therapy, the term, seems to connote. And of course, substance abuse, which is a historical term that really criminalized this disease. It was part of the criteria back in, prior to the current DSM, which is the Diagnostic Statistical Manual of Mental Disorders, or Bible, so to speak, of psychiatric conditions that exist, put out by the American Psychiatric Association. And substance abuse was eliminated because one of the criteria was actually that you get in trouble with the law. So it actually completely criminalized a disease. That was a criteria, was that you had to be a criminal. And it's just astounding to me that we got away with that for so long as a medical community, and that we didn't see the error of our ways much sooner. Great, I'm grateful that at least we did, and that was in 2013 that the newest DSM came out, and an updated edition is coming out in 2022, which of course still, has this term eliminated and has the substance use disorder designation. Now, what we don't think that we think we think. I know lately there's been a lot of these implicit bias tests going around. I know in my department here recently, we were told we had to complete an implicit bias association test as part of our DEI initiative, or diversity, equity, and inclusion. And part of that is because bias is universal, right? We all have biases. I had biases when I did that test that I didn't even realize. And we all do, because they're unconscious, and our brain takes shortcuts because it's easier. It's easier for all of us. And different people's brains take different shortcuts depending on what the situation is, depending on what your life experience is. And the shortcut that most brains tend to make when we hear things like substance abuse or addict or alcoholic, the shortcut is to one of negativity, right? The shortcut is to one of a negative space. When you hear that, you already are kind of thinking negatively, and you may not realize it at all, because it is true even for highly trained and experienced health professionals. So bias in clinical practice can actually play out similarly. So there was a study in 2016 looking at around 300 physicians at Massachusetts General Hospital in Boston. And they were looking at the physicians who are the primary care providers. So they were in the hospital, internal medicine, family medicine, the internists that are taking care of people who are hospitalized. And they wanted to look at their attitudes and clinical practices as it concerned individuals with substance use disorders. What they found was pretty astounding. 38% felt that substance use disorder is actually different than other chronic diseases because people who use drugs or alcohol are making a choice, which, if you remember, we talked just now about how it's not a voluntary choice, right? That was one of the erroneous thoughts behind what addiction is. And yet this is what these very highly trained professionals are thinking. 14% felt that medication treatment using opioid agonists is simply replacing one addiction for another, which again is not true, and what the term replacement or substitution therapy seems to imply. So again, when we hear this kind of language, that is what we end up thinking. And most shockingly, 12% thought that somebody using drugs is committing a crime and deserves to be punished. So when we hear things like substance abuse that historically was linked to criminal behavior and activity, our brain is then just thinking about, well, if you're using substances, that means you're a criminal, that you have criminal activity, because that's what that is, which is, again, completely false, and a narrative that has unfortunately been propagated historically amongst our society. So language does impact patient care, whether or not we realize it, because our biases impact how we treat patients. So the attitudes that we hold and the implicit biases that we have really drive clinician behavior. We're more likely to assign blame to a patient if they're called a substance abuser than if they are called a person with a substance use disorder or a patient with a substance use disorder. We're also more likely to agree with the need for punishment if they're called a substance abuser, which, again, if you go back to thinking about the criminal activity and criminal behavior, right, that punishment goes with that. And so all of this is tied up in our perceptions and our unconscious bias of what that might mean to be a, quote, substance abuser versus what it means to be a person, right? To go person first language and sharing our humanity and describing somebody as the individual that they are, and also having a substance use disorder. So bias impacts clinicians as well. Not only are we doing a disservice to our patients, we are doing a disservice to ourselves. Health professionals in general, they've done lots of studies on this, have pretty negative views about patients with substance use disorders. And this is actually universal. In many ways, you would think psychiatry, my field, would have more favorable views because this is what we see and what we treat so much of the time. And unfortunately, that's just not true. Psychiatrists hold equally negative views about patients with substance use disorders, as do other specialties in medicine, which again is linked to decreased empathy for these patients. If we have negative associations, we're not going to be able to empathize and develop that therapeutic rapport and that alliance with the patient that has been shown to increase positive outcomes. So not only are we decreasing our empathy for the patient, we also know that empathy is a large part of burnout and losing our empathy for the patients. I'm sure you've heard about burnout with the COVID pandemic, and the burnout amongst health professionals is astounding because of everything that they've gone through. Well, that part of that, what happens with burnout is you get this compassion fatigue. You just simply can't give anymore because you can't empathize anymore because you're so broken down. And when we don't empathize with our patients with substance use disorders, it contributes to developing burnout. And has been a contributor to burnout. So not only are we then doing a disservice to our patients, we're actually doing a disservice to ourselves, and we're increasing our own risk of developing burnout simply because of how negatively we view patients with substance use disorders. So substance use disorders are very common. We talked last time about how 1 in 7 people, so I am not sure how many are logged in right now, but I'm sure a number of us in the room, statistically speaking, would develop a substance use disorder over the course of our lives based on the fact that 1 in 7 Americans will develop a substance use disorder. I recently read a statistic that something like 25% of Americans misuse alcohol, right? So we talked about alcohol misuse, and that includes binge drinking, and hazardous drinking. But that is astounding to me that it was that high. I actually did not realize it was 1 in 4 who actually currently misuse alcohol. And so it really is all around us. And we know that continual misuse then really increases our risk of developing an alcohol use disorder. So it really is an overwhelmingly common condition. Now, the traditional approach to treatment, and I'll just touch on this briefly because I want to focus more on the novel, more patient-centered treatment approaches. This historical idea that substance use disorder is acute and curable, because what the going theory was that if you just remove the person from the substance, that they'll be okay. They'll stop using because they don't have access to it anymore. They're going to be locked away in a facility for some period of time, usually 28 days. And then once they're done going to groups and doing mutual aid groups, then they can leave and they are cured. Then they're not using the substance anymore. Well, unfortunately, we know that that's completely not the right way of going about it because it leads to a revolving door. And if that would have worked, we wouldn't be where we are today. If that's the historical treatment, we wouldn't have 93,000 overdoses. We wouldn't have the rising rates of alcohol use disorder and alcohol misuse, right? The priority was always just to remove access to the drug and not to get to the bottom of what's driving somebody's addiction. The services were also time limited, and we know now that addiction is chronic. We talked about those brain changes really take a long time to develop, and we need to be able to provide treatment for somebody that matches that, right? If you've been drinking for 30 years, that's not going to change over the course of 28 days. That's not realistic, and that's not a realistic way of looking at it. Logically, it doesn't even make sense, and yet that's what we've done in the past. So we know now that we need a more longitudinal approach to care outpatient care, continued engagement in recovery. Sober living facilities is one avenue for that. Mutual aid groups is another. And we know now that all of these components are essential to somebody's recovery and that it's going to look different for every person. Abstinence historically was the only goal. And patients were not allowed medications because if you were on medications, it was thought you're not actually truly abstinent, which again is not true, of course. And now we know that for some patients, medications are life-saving. And they prevent overdose and death and a variety of other negative outcomes. And for others, medications maybe are not as helpful or they're not interested in that, and that's okay too. But again, it speaks to the individualized nature of the kind of treatment we have now versus the traditional treatment approach, which was very cookie cutter, and everybody got the same 28-day treatment that your neighbor gets. So now this more patient-centered view is something that I like to call harm reduction. So harm reduction is a conceptual and clinical framework aimed to decrease the negative consequences of substance use without necessarily reducing the consumption of substances. So that's a big one, right? Because we're not talking about abstinence. And in many cases, we're not talking about even reducing the use. We're just talking about safety and how to keep things safe. I am the co-director of the Addiction Psychiatry Consult Service. We will get patients we see that we're consulted on that have alcohol use disorder and have no intention of stopping using alcohol. And I'm not there to dissuade them, right? That's not my job. But what I ask them is, what do you do when you need to drive when you drink alcohol? Do you have a designated driver? How do we make sure you don't drive intoxicated, right? All of these things that are so important to reducing harm. Likewise, a very notable harm reduction strategy is a needle exchange or a syringe exchange program, where you're reducing the rate of HIV and HCV, hepatitis C, transmission by over 50%. Right? That's huge. It costs $500,000 to treat one patient with an HIV diagnosis over the course of their life. And we can reduce those diagnoses by 50% amongst individuals who use injection drugs simply by providing clean and safe equipment. It seems like a no-brainer, when we're thinking about it as harm reduction, but in many circles, it is seen as radical, and some believe it is to be enabling. So it is something that I'm hoping we can talk about during our discussion portion. So harm reduction is an evidence-based public health approach, right? Again, we're looking at the positive aspects of care. So it's a strengths-based approach. It's not one size fits all. It's not cookie cutter. We're not sending everybody to rehab. We're really meeting the person where they're at, and we're staying with them wherever that journey might take us. The recovery is not defined by abstinence. It's not defined by our goals. It's defined by the patient's goals. I saw somewhere recently this idea of program-centered care and patient-centered care. So historically, we employed program-centered care, where the program dictates that you are sober. The program kicks you out if you use, right? We're doing everything based on what the program wants as opposed to what the patient wants, right? And now we're looking at it more from the lens of the patient. We're there to help them no matter what their needs might be. There's no progressive steps to complete. It's not a circumscribed program. It really is a treatment approach that is designed to enable somebody to achieve their full potential. So these approaches are personalized. There's a spectrum of strategies. I've mentioned some already, like safer drug use through syringe and needle exchange programs, the use of naloxone, which is an overdose reversal agent for opioids. Life-saving, absolutely life-saving, and not enough of it is in our communities. I know the CDC is really pushing now to get more and more naloxone into the hands of individuals so they have it on hand like a fire extinguisher. You don't ever want to use it, but if you have a fire, you certainly want to have a fire extinguisher on hand. And that is exactly how harm reduction works. We also have moderation management, and of course, abstinence. Abstinence is also a harm reduction strategy if the patient wants it to be. That's the key here. There's nothing wrong with abstinence, but the patient has to want abstinence in order for us to work towards that goal. It shouldn't be our goal as the individuals working with the patient or the client. So again, the goals of harm reduction do not necessarily include reducing the consumption of substances. We're focusing on functional impairment, not sobriety, and really wanting to, again, restore the person to optimal functional capacity to be a contributing member of society in the way that they wish to be. So these evidence-based services of harm reduction are really designed to enable somebody to reduce or eliminate alcohol or other drug use, to address the associated physical or mental health problems, and again, to restore the patient to maximum functional capacity. So to recap our take-home points, stigma is universal, right? It affects each and every one of us because of the unconscious bias, and it impacts patient care or lack thereof, right? Our desire to work with these folks is going to be a lot lower if we think negatively of them. And that's unfortunately the status quo. Addiction is a common and treatable chronic medical illness, especially using the approaches of harm reduction. And your words really matter, and you have the power to decrease stigma. So it's something that I like to preach almost because I really do truly believe every single person has the power to decrease stigma simply by changing the way we talk. It seems like such an arbitrary, trite thing, and yet it is so impactful, and the research proves its impact. And each and every one of us can do it. You know, we don't have to go to special school. We don't have to have special training. We just have to change the way we talk. And that is, you know, one of the big things I always try to talk about. Now we have several discussion questions that were already submitted, and I have them on separate slides just because there were so many on one slide. But I wanted to talk about one because this is a question I get very often, which is, you know, what should you do when a friend or family member you're talking to self-identifies as an addict or an alcoholic, right? Because we just got done talking about how we want to put humanity first and we don't want to label individuals. And so how do we approach that, being, you know, the peer specialist or being the person working with the client? And it's kind of it's a tough situation in some ways, and then it isn't in other ways. So it is a tough situation in one way because we're taught that that language is not okay. So we're hearing it and it's a little alienating. In another sense, you know, again, this offers us an opportunity to uphold patient autonomy, patient agency, and to respect the patient, you know, or the person. I always talk about patients because that's what I do, but, you know, to respect the person. If that is how somebody wishes to self-identify because they find that to be empowering or motivating, right? I've had some people say, you know, reminding myself that I'm an alcoholic is what keeps me from drinking every day. And that is what keeps me going, right? Why would I want to take that away from somebody, right? I would never do that. So certainly people can self-identify in any way that's going to be beneficial for them. But I, as the professional, am not going to label them that way, right? So if they're saying, hey, I'm an alcoholic, you know, I might respond with, yeah, you have an alcohol problem, you know, and let's talk about your problems with alcohol, without, you know, needing to label them yourself, right? You don't need to necessarily repeat all of the language that the individuals use. But again, it really is up to the individual how they wish to self-identify. And it's important that we respect that. There's a lot to be said, again, about patient empowerment, particularly in marginalized groups. We know that many marginalized groups have really reclaimed very negative terms that are empowering, you know, to that group. And I think that's beautiful and a wonderful take on it. So again, we would never want to rob our patients of that opportunity to use that language for good for themselves. So it's something that, you know, I wanted to talk about because it is something that we often get asked.
I did get a couple of questions so far in the chat whenever
Yes,
you
please.
want to address those.
Oh, absolutely. I even have a special slide, questions from the chat. So you can just go ahead and knock them out.
Sure, and then we can go back to some of those if
Yeah.
if we've got some time. So
Absolutely.
someone asked, is there research linking COVID and the pandemic to the increase in overdoses? If not, do they plan on conducting a study to find if there is a correlation? Basically, you know, sometimes
Yeah.
correlation, not causation, that kind of thing.
Yes, yes, that's an excellent question. So there is certainly research that shows that individuals with substance use disorders are disproportionately affected by COVID, meaning that having a substance use disorder increases the risk of actually getting COVID. And that's what they have shown over the past year. So that's one element. The other element is that temporally, in terms of what happened, you know, in our communities when COVID first started, everything shut down, everything went to telehealth. There is absolutely a link with increased substance use, increased rates of substance use disorder diagnoses. You know, alcohol sales went up 40% nationally during COVID. And of course, it's also been linked to increase in overdose deaths. And part of the reasons that people are now speculating, obviously, again, you can't prove some of these things, but one thing that really makes sense is the fact that for many people, instantaneously their treatment was taken away. It was abruptly cut off. If they were going every day to an in-person AA meeting, and now that AA meeting isn't meeting anymore, and that's what kept them going, that's what they looked forward to every day, they don't have that camaraderie, they don't have that support or fellowship. And that is very challenging to just have the rug pulled out from under you. Many, at least here locally in Omaha, Nebraska, where I am, you know, many of the treatment facilities temporarily shut down. The residential treatment facilities didn't take any new patients because as they were trying to figure out how they were going to address, you know, the masking and all of those sorts of things. And so then patients were basically denied care, you know, denied treatment in service of safety in one way, right, in public safety of public health. And yet for the individual patient, it was very deleterious and truly was problematic. So there's that element of losing access to your services. There's also the COVID aspect of isolation. And there has been a lot of research on isolation and depression and anxiety symptoms. So that much is true that this period of the pandemic has resulted in an increase in self-identification of anxiety and depression symptoms. Now we know that anxiety and depression predispose to alcohol use and other substance use. So it makes sense that for some people coping with the isolation, with the negative feelings, with job loss, being furloughed, I mean, there's so many factors that people would use substances as a way to cope. And unfortunately, over time, that can change the brain. And for some people, it has. So COVID has actually been transformational in a negative way for the substance use treatment community, for patients with substance use disorders, and for patients with new substance use disorder that didn't previously have one.
Yeah, thank you for answering that question. I always had like the speculation and doubt in the back of my mind, you know, what are we giving up for physical health or giving up in mental health that we're using to protect our physical health? Just because of the isolation standpoint. So I didn't know if any of that was confirmed or if it was just speculation by experts at this point.
Yeah, no, that's an excellent way of looking at it. And I haven't heard that said in that way. And I love that. You know, what are we giving up in terms of mental health to focus on our physical health? You're absolutely right. I don't think there's ever going to be a way to prove, right? Correlation is not causation, but the correlation is there. I mean, the correlation, the data is there, the statistics are there. And now the speculation is in thinking about the causation, right? Because we already know that the correlation is there.
Thank you.
Yeah, thank you so much, Lillian. And if anybody else, if you want to unmute and ask your question directly, just raise your hand and hopefully we'll catch it. Otherwise, send me a chat and say, hey, I want to ask a question directly. So Veronica has raised her hand and she did ask a question in the chat. So maybe she'll want to do that directly.
Please.
Hi, thanks for taking my question. In looking at the stats that you provided, I was wondering what was the source of the research and what were the demographics in the research? Like what ethnicity groups represented what numbers and what ages? And I was also wondering if that information is provided in cultural competency training for occupations within the healthcare system.
Oh, that is so interesting. So which statistics in particular are you referring to?
The 1 in 7 people will develop a substance abuse disorder or
Yeah, so that actually comes directly from the Surgeon General's Facing Addiction in America text, which is available for free online on the SAMHSA website, government website. You're able to download it. Back when it first came out, you could order a paper copy, which is what I have. And they don't delineate the racial, demographics or anything like that. But we also know that there's disproportionate rates of substance use disorder in minority communities. And that is for a variety of reasons, not the least of which are social determinants of health and access to care. But so that's a really valid question. But in the surgeon, at least in that text, they didn't differentiate, amongst the demographics or characteristics of the 1 in 7.
Okay, thank you for that. I was just wondering about that because I originally am from Canada, and I know in Canada when they did their stats, I don't know what year it was a long time ago, I'm kind of old, but they they found that the majority of substance, or it was regarding alcoholism, and they found that in the racial demographics that it was non-Indigenous people that had the highest rates of substance abuse with alcohol. So that's why I thought of that question.
Mm-hmm. Yeah, there's a variety of studies out there. I mean, so again, that 1 in 7 doesn't differentiate, but there in the literature and even sometimes in just news media, when they report on studies, there are really disparate numbers in terms of certain types of substance use disorders, and then certain minority groups, certain disenfranchised groups, things of like, even for example, the LGBTQ group sort of demographic also has higher rates of mental health conditions, including substance use disorders. So there is a variety of research there.
Mm-hmm. And I was also wondering about the cultural competency training, because just from observation and my experiences with children in schools and stuff, and how, and we're speaking about stigmatizing adults. We're not considering that a lot of these adults have children that are in a school system who are taught by teachers who have this stereotypical mentality toward these children that are from, different ethnic groups. And that's why I was wondering, like, is this information included in any training that even teachers take? I have to.
Yeah, I think it would be excellent if it were. I can tell you, it wasn't in my, onboarding information, but I do think it would be awesome if it were. Like I said, right now there is seems to be a big initiative to do implicit bias training across the country in a variety of settings, and some of that could touch on substance use disorders, but really it's mostly looking at race, socioeconomic status, more of the, kind of larger social determinants.
Mm-hmm. Okay, thank you for that.
Thank you so much, Veronica. And I do have 3 more questions here. So the first one is, how do you start a conversation about treatment with a person with substance use disorder?
Yeah, that's an excellent question. I love that question. So the thing is, you don't start a conversation about treatment. So that's the answer. And what does that mean? Well, you usually start with asking the individual whether they identify that their substance use is problematic in any way. Right? If somebody tells you, I smoke a gram of crack every day, my response might be, okay, do you find that problematic at all? Or has that ever been problematic for you? Has that gotten you into trouble? And I would just go with wherever the patient takes that, because they may not realize that they have a substance use disorder. And sometimes even when they realize it, maybe they're not ready to take action, right? They're not ready to even have a conversation about treatment. On our consult service, like I said, we see the patients in the hospital. One of our requirements, actually, in order to go see a patient, is that they are willing to talk to us. That is our one requirement. So many times the team, will say, no, we want you to talk to them because they keep ending up back here, detoxing, and we want them to stop. But the patient's not ready for that conversation. And so us going in and trying to confront them about it is actually going to be counterproductive. We've certainly had experiences, where the patient was not informed and was not asked permission in advance, which was very unfortunate, and did not wish to speak with us, which is, we respect that, 100%. And so the conversation about treatment really, in my book, arises when the patient themselves identifies a want for treatment, a want for that conversation. But I like to explore first what it means to them, right? What their substance use means to them.
Okay, and question number 2 is, are some states affected more than others by substance use disorder?
Yeah, that's a great question. So I will say every state is affected by substance use disorder, but the way in which it's affected may differ. Now, for example, I trained on the East Coast where we had a lot of opioid use disorder patients. It was the most common use disorder that I treated in training, followed by alcohol use disorder, right? And that was in Massachusetts. Here in Nebraska, we don't have that much opioid use disorder, very minimal, to be honest. Here, alcohol use disorder is number 1, followed by methamphetamine use disorder. Whereas out on the East Coast, I saw one person with methamphetamine use disorder my entire 4 years of residency. One person, because it was just not a drug that's commonly used in that region. So, every state really is affected, but in their own way. Here in Nebraska, we've had a rise in methamphetamine overdose deaths as well. But that's not something that's shared amongst other states where methamphetamine maybe isn't used as often. Likewise, we've had lower numbers of opioid overdoses, in part because we have lower rates of opioid use disorder than some of the other states. So every state is affected just in a different way.
Okay, what about other countries? Are there countries that's the third question, is which countries are affected the most by substance use disorder, if you know?
Yeah, that's a great question. And I'll be honest, I don't know statistics of other states, of other countries in terms of the rates of the substance use disorders. However, what I do know is that many other countries have a far more effective treatment system. And I mean far more effective, right? So in France, medications for opioid use disorder have been freely available, without any special licensure, but from any physician for years and years and years. And many patients are stabilized on those medications very early on in their disorder, right? So again, many of the other countries just have a different system. Like the UK, which has a national health system, also has a different way of approaching it. And so while every country has, I'm sure, their own problems with substances, in countries where they have less regulation of substances, like Portugal deregulated all of their substances. So no drug is like illegal. And their rates of HIV and hepatitis went down because their rates of injection drug use went down. And so it's interesting how that works. But yeah, every country has their own kind of thing going on. I am more of an expert on what's happening in our country.
Right. Okay, so we've got another question from Becky. Have you ever worked with jails to treat inmates for substance use disorder, opioid use disorder, while incarcerated or nearing release, in order to set them kind of on that right path once they're released?
Yeah, that is an excellent question. And gosh, I wish everybody had your mindset. I really do. So this is an ongoing controversy with federal prisons as well as with local jails and prisons. We know that actually our correction system is the #1 provider of mental health services in our country, because over 50% of individuals who are incarcerated have at least one mental health condition, including a substance use disorder, right? So it is incredibly common amongst inmates, and it is essential that we treat it. Unfortunately, very little treatment is provided, and it can lead to some pretty drastic consequences. So like you said, getting them stabilized on a medication before release is what's going to set them up for success and prevent overdose. unfortunately, what ends up happening is that, they're sent to jail maybe for 10 days or what have you. And during that time, they're cold turkey detoxed off of their opioids that they may have been using. Their tolerance goes down. Once they're released, they go back to using the same amount they were previously. However, because their tolerance has gone down, now they overdose accidentally and potentially die. And we absolutely have seen that because of a lack of treatment services in jails. Successfully in Massachusetts, it went up to the Massachusetts Supreme Court, an individual, an inmate, a female inmate who was taken off her methadone, that she was attending methadone clinic and receiving methadone. She was taken off her methadone, was deemed to violate the Americans with Disabilities Act because the prison took her off her methadone, whereas that was for her medical condition, and they deprived her of that. And so she won that in the Massachusetts Supreme Court. So hopefully they're now beginning to institute medications for addiction treatment in the prison system, at least there.
All right, thank you. We have 8 minutes left. So just a reminder, just chat. You can either unmute or send me a chat for the questions. If you want to go back a few slides, so these are the questions that you have on the 4 slides that we had for the people that were in person for the August 12th event. And so I would like to hear maybe some feedback from the participants here, or even from you, Dr. I think that you probably heard some interesting conversations, and maybe share some of like on harm reduction, or enabling people, that kind of thing. I think some of these things really come up a lot, and I think maybe you got to hear some gems, if you could share.
Yeah, no, I definitely did. And I would love to hear from the group too, about this, about their thoughts about how to incorporate harm reduction principles into practice and into daily life. I think this question of how to support a person without enabling them is one that is so commonplace, in medicine and in social services and pretty much everything, because we don't want to enable individuals, and yet we want to respect the person and support them in their recovery, whatever that might look like. And I think, one way of doing that is to separate the person and the disease, right? Because they're not the same thing. And I think, again, when we use words like alcoholic and addict, we're making them out to be the same thing, right? The person is the disease. And so when we look at the person, right, and we're helping the person in what their goals are, we're not enabling the disease, right? We're supporting the person. And I think that once we separate those out in our heads, in our own heads, I do think it's a lot easier for us to be able to approach it that way, because you want to separate the behaviors, right, which are symptoms of the disease, from the person, right, from the individual in front of you. And again, those are 2 different things that get conflated because of the language that we use. But I think when we do separate it out, again, it's a lot easier to see it clearer, if that makes sense. Does anybody else have other thoughts?
Just raise your hand and unmute if you do. One of the things that came up for me personally is now when I hear someone saying, "Oh, that's a drug abuser," or it's there's no clinical setting here or anything like that. It's just regular daily life. How can I make that a teachable moment without looking like I'm scolding them or you know what I mean?
Yeah. Oh, God, that's such a tough one. I come across that quite a bit because even in non-clinical settings, sometimes my superiors, like my boss, my chair, will use, language like that. And you think about the power differential and how, you don't want to embarrass them in front of, the whole group. And at the same time, you want to be able to tell them that that's not okay. So depending on the circumstance and the power differential, if it's a peer, I think pulling them aside after the fact, and saying, "Hey, earlier when we were talking, I noticed that you said substance abuse, and I don't know if maybe you weren't aware, but there's a lot of research recently that's come out that has shown that using that kind of language actually, impedes patient care. And if we say substance misuse, that ends up being a better alternative, and even offer some resources. I know at the August event, we offered some resources, which Lori has, that actually show you the words not to use and the words to use and why. It gives you the rationale, and just sharing those resources widely, amongst your organizations, amongst your HR, like when somebody gets hired, they should get those, right? And so that way, with my students, those that are, my subordinates and my residents, I actually tell them from day one, I will correct you. It's not personal. I correct everybody. And what I do is just actually correct them in real time. So if they do say, substance abuse, I say, oh, substance use disorder, or, alcoholic, oh, a person with an alcohol use disorder. So, and I just, without really any bravado or anything, just correct them. And then like, oh, right, yes, okay. And then, moving on. So when you're very kind of non-judgmental about it and it's just routine, correction, it's part of the learning experience for them too.
Absolutely. I really like that. There's a lot of research on this.
There is, exactly, because it's not like you being like, oh, you're bad, it's like, oh, hey, like I wanted to share this with you.
Right. And I like how you do it after, rather than it would feel less of a scolding, less of a gotcha moment if you waited, whether there's other people there or not, if you wait until afterwards. Because I really do believe that is some of what we can do, like all of us, every single person that can reduce stigma is kind of check ourselves and then in a kind way educate others on it, for sure. So yeah. I've asked Becky to put in the chat that handout that we gave at the in-person event that shows, say this, not this, right? And the reasoning behind it. So I really like that handout. Hopefully she can find that real quick and put it in the chat. I do have a survey that I'd love for everyone to take. And it'll just help us with planning future events, which I know we will. I know with this Drug-Free Communities grant, this is one of the things that we can do with it, right? And so yeah, and if anybody needs a certificate of attendance, just contact me, and I can definitely get you that. I'll put my email in the chat as well, or if you want a recording of this session. So now we've got a recording of the August 12th, and we'll have a recording of this. And together, I really think these two things can make a big difference.
Absolutely.
Here's my email address. And let's see. Let's see. So Becky did not put that in there. She must not have found it. I can, what I'll do is I have everybody's email address in the follow-up. When I send out the recording of this, I will include that packet of information. So, oh yeah, it's not letting her upload it. That makes sense because it's big. So,
okay. It is a big file.
Probably too big for Zoom. But it is 3:59. If anybody, this would be the last chance to ask Dr. Balasanova any kind of questions or give us any kind of feedback on what you've seen since the August 12th event or anything like that. Also, you can email me, you can contact me, and let me know, kind of what's been happening since we originally welcomed Dr. Balasanova to Wright County. What's been happening. So, Maddie, go ahead, Maddie.
Oh, thank you so much, Dr. Balasanova. I loved your presentation last time, and today was the same. I just wanted to say Happy Recovery Month to everyone. September is Recovery Month. It wasn't last time we were together. So there's a lot of exciting things happening for advocacy with recovery. And it's beautiful, the language that you've equipped us with to make sure that we're continuing to do that. So thank you very much.
Thank you. Thank you so
thanks,
much.
Maddie. Thank you so much. Well, and we are straight up 4 o'clock. I want to honor Dr. Balasanova's time and everyone else's. I want to thank everybody for your participation and your attendance. And thank you so much to Dr. Balasanova for your time and all of the effort that you've put into making these events exactly what they were meant to be as far as building capacity of understanding this particular subject matter. Thank you so much.
Well, thank you, Lori. Thank you for the opportunity. And you guys, Lori's amazing and she organized all of this. So kudos to Lori too.
Oh, I had some help. But thank you for saying that. Thank you. I appreciate
Bye,
it.
everyone.
Okay. Oh, Maddie says I rock. I'm going to stay on just for a little bit in case anybody has anything to let me know about. Great to see everyone.